Hello class, this is my video presentation for this module. This is the case of a 20-year-old female that came from Honduras and presented to the emergency room complaining of shortness of breath, intermittent palpitations, and bilateral low extremity edema. She admitted that the symptoms has been going on for about 3 days. She had experienced similar symptoms in the past, but they were not as severe as they were now. The patient also mentioned experiencing a more pronounced dyspnea on exertion. She used to be able to walk to the store around the corner from her house, and now she needs to stop multiple times to catch her breath. She also mentioned of noticing what appeared to be an irregular heartbeat that will come and go. Her pertinent medical history. She mentioned that when she was 11 years old, she had an episode of fever with various joint pains that involved the knees, the elbows, and the ankles, and it lasted for about 2 weeks. She remembered that it kept rotating around. At times it was the knees, and then it turned to the ankles or to the elbows. She remembered the painful episodes, however, she did not remember the treatment that she received. She was an orphan and moved around a few different families and never had the opportunity to meet her biological parents. She mentioned that about 3 days ago, she had a molar extraction done. She noted that after the procedure, she developed a productive cough with yellow sputum. She mentioned that she had been experiencing a sharp and stabbing chest pain that radiated to her back. The pain lasted about 30 minutes, and at times it occurred while she was laying down resting. Admitted to frequent throat infections that require antibiotics in the past. And she remembers being told when she was younger that she had a problem with her heart, but she was never told what the problem was. And she denies having a history of asthma. Her surgical history was negative, and she did not know her biological parents' history since she was adopted. She admitted to vaping, smoking marijuana, and an occasional beer. Her review of system, she admitted to an unintentional weight gain, subjective fevers, no chills or sweats, denied ear pain, nasal congestion, and admitted to a sore throat. Admitted to shortness of breath and a productive cough with yellow sputum, and palpitations with dyspnea on exertion and lightheadedness. Admitted to chest pain that was sharp and stabbing in nature and it radiated to the back. There was no nausea, no vomiting, diarrhea, abdominal pain, or difficulty swallowing. She denied having any urinary symptoms. And she was negative for bruising tendency or swollen lymphatic glands. Denied excessive thirst, heat, or cold intolerance. Admitted to joint pain that kept moving from joint to joint, and denied muscle pain or decreased range of motion. There were some red areas on her anterior thorax, and there was no focal weakness, no paresthesias, no headaches, no numbness or tingling, and denied any seizures or tremors. On physical examination, her vitals were a temperature of 38.5 degrees Celsius, a heart rate of 124 beats per minute, irregular and irregular pulse, a respiratory rate of 40 breaths per minute, and a blood pressure of 130/60. Her SpO2 was 90%. She was drowsy and in respiratory distress, and it was noted that she was tripodine. Her skin was cold and clammy, and there was no jaundice, hives, or petechia. Her pupils were equal, round. Extraocular movements were intact without nystagmus. There was a clear conjunctiva and no icteric sclera. She was normocephalic, rheumatic. There were moist mucous membranes with no rhinitis. The oropharynx was noted to be hyperemic, with enlarged tonsils without exudate. The neck was non-tender and supple with no nuchal rigidity. Was noted that there were distended veins, but no lymphadenopathy, and there was full range of motion. The chest was symmetrical, with bilateral expansion. Coarse crackles diffuse over the lung fields were noted, along with the use of accessory muscles with retractions. There was no stridor. The patient was tachycardic with an irregular rhythm, and a 4 out of 6 holosystolic murmur noted with radiation to the axilla. The abdomen was soft, non-tender, with mild distension and a palpable liver. There was no rebound or guarding, and she did not have any CVAT to palpation. It was noted a 2+ pyridema in bilateral lower extremities to the distal 1/3, without no lymphadenopathy. Her labs, the CBC and differential, CBC was elevated at 19.9. The RBC, hemoglobin, and the crit, along with the platelets, were within normal range. Neutrophils were elevated at 91.4, and lymphocytes were low at 8.1. Her chemistry was within normal range. PTT, INR, and PTT were within normal range. Troponin I was normal, and TSH was normal. The urine tox screen was positive for cannabis, and her UA was normal. A 12-lead EKG was performed, and it showed atrial fibrillation with rapid ventricular response and non-specific ST T-wave changes. Her chest X-ray was consistent with cardiomegaly, pulmonary edema, and there was a haziness at the right pericardiac border. A 2-dimensional echocardiogram done by cardiology showed moderate to severe mitral stenosis with moderate mitral regurgitation and moderate aortic regurgitation with left and right ventricular dilatation. There was a dilated left and right atrium with no evidence of thrombus and a dilated main pulmonary artery. Differential diagnoses on these patients are endocarditis. Endocarditis is an infection of the endocardium, which is the inner lining of the heart chambers and heart valves. Endocarditis generally occurs when bacteria, fungi, and other germs from other parts of the body, such as the mouth, spread through the bloodstream and attach to damaged areas in the heart. If it's not treated quickly, endocarditis can damage or destroy the heart valves and can lead to life-threatening complications. Viral myocarditis. Myocarditis is an inflammation of the heart muscle, the myocardium. Myocarditis can affect the heart muscle and the heart electrical system, reducing the heart's ability to pump and causing rapid or abnormal heart rhythms, arrhythmias. A viral infection usually causes myocarditis, but it can result from a reaction to a drug or be part of a more general inflammatory condition. Signs and symptoms include chest pain, fatigue, shortness of breath, and arrhythmias. Severe myocarditis weakens the heart so that the rest of the body doesn't get enough blood. Blood clots can form in the heart, leading to stroke or heart attack. Another differential is functional mitral regurgitation associated with a viral illness, such as viral myocarditis. Along the differentials also we can include mitral valve prolapse due to degenerative myxomatous disease. Degenerative mitral valve disease is also called mitral valve prolapse or floppy mitral valve syndrome, which is caused by myxomatous degeneration of the mitral valve tissue, whereby elastin and collagen bundles are disrupted, and proteoglycan deposition in the spongiosa resulting in the leaflet thickening and redundancy. The working diagnosis on this patient was rheumatic valvular heart disease. The treatment the patient received while in the emergency room was: the patient was alert, awake, with a normal blood pressure. However, she was unstable. She was symptomatic. She was on O2 at 4 liters per minute, and it was responding by decreasing the tachypnea and increasing the PO2. The fact that the patient had mentioned earlier that the episodes of abnormal heartbeats appear to come and go spontaneously was taken into consideration during her treatment. She was asked how long this episode has been going on, and she voiced that it began shortly before arrival to the ER, which is less than 48 hours. For that reason, the patient was treated with dialtisam with the purpose to slow the heart rate down. A repeat ECG was done after the patient's rate slowed to 100 beats per minute, and it showed a normal sinus rhythm with no pre-excitation features and a prolonged PR interval. The patient was also treated with aspirin, 2 grams PO, that was administered immediately after the diagnosis of rheumatic fever, along with benzathine G, 1.2 million units IM, and 500 mL of normal saline IV. The patient was admitted to the medicine service with a cardiology consult for further evaluation and treatment of rheumatic valvular heart disease. In summary, the patient showed signs and symptoms consistent with acute rheumatic fever and rheumatic valvular heart disease. She presented with dyspnea, and she had a dental procedure done 3 days earlier and developed a productive cough with yellow sputum. She had a sharp stabbing chest pain radiating to the back, lasting for more than 30 minutes that happened even at rest. She had fever, joint pain, myalgias, and a history of frequent streptococcal throat infections during the childhood. The physical findings were concerning and provided crucial information. She was drowsy and in respiratory distress and preferred the tripoded position. Her BP was 130/60. Her heart rate was 124 beats per minute, irregular. The respiratory rate was 40 breaths per minute, associated with a temperature of 38.5 degrees Celsius. Her skin was cold and clammy, indicating that the patient was in shock or about to go in shock. Her throat was hyperemic in the posterior pharyngeal wall, and her tonsils were enlarged. The immediate administration of O2, dialtisam, antipyretics, and anti-inflammatories, such as aspirin, were crucial in the treatment of this patient. Teaching points. Acute rheumatic fever is a multi-system disease characterized by the involvement of the heart joints, central nervous system, subcutaneous tissue, and skin. Except for the heart, most of these organs are only mildly and transiently affected. The clinical diagnosis depends on criteria involving these systems as well as laboratory findings indicative of recent streptococcal infection, the so-called Jones criteria. What is the Jones criteria? The Jones criteria consists of two different criteria, a major criteria and a minor criteria. The major criteria consists of arthritis, carditis, Sydenham's chorea, erythema marginatum, subcutaneous nodules. The minor criteria involves fever, arthralgias, elevated CRP, rising ESR, and a prolonged PR interval on each ECG examination, which is consistent with acute rheumatic fever and rheumatic heart disease. Rheumatic heart disease is the predominant cause of mitral stenosis. A history of rheumatic fever can be elicited from approximately 60% of the patients presenting with pure mitral stenosis. There is a 2-to-1 female to male incidence. In developed countries, the disease has a latent period of 20 to 40 years, with another period of almost a decade before symptoms require surgical intervention. Once significant limiting symptoms occur, there is a 0 to a 15% 10-year survival rate without treatment. Severe pulmonary hypertension is a poor prognostic sign. The mean age of presentation in North America is in the 5th to the 6th decade, and more than 1/3 of the patients undergoing valve repair or replacement are older than 65. Now, remember, this patient was only 20 years old, but she was from Honduras. She was not born and raised in the United States. Approximately 1/5 of the patients with post-rheumatic heart disease have pure insufficiency. 46% of the patients have stenosis with insufficiency, and 34% have pure stenosis, and 20% pure insufficiency. Mitral insufficiency is more likely caused by a floppy mitral valve with ischemia and endocarditis as other essential causes. And as per Berkey, the prognosis of these patients in rheumatic mitral valve disease is inconsistently repairable, and the long-term outcomes after surgical repair are not as good as for valve repair for mitral valve prolapse due to the leaflet and the chordal scarring that takes place. In addition, leaflet scarring may be progressive after repair. However, rheumatic mitral valve stenosis that is not associated with severe chordal fusion or shortening or calcifications may be treated with either percutaneous or open mitral commisurotomy, which with a high degree of long-term success. This is the end of my presentation. Thank you for taking the time to listen to it. Have a nice day.